Good evening, everyone, and thank you for joining the Intellectual Disability Healthcare CPD webinar. I am Hannah Coffey, Intellectual Disability Program Coordinator, and I'm joined tonight by my colleagues Claire Woods and Jennifer Brennan, with the Intellectual Disability Service Navigators with Central and Eastern Sydney PHN. We also have with us tonight co-facilitators Kylie Scott and Dr. Jessica Murphy, and Kylie and Jess will introduce themselves in a minute. I'd firstly like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. I would also like to acknowledge people with lived experience of disability, along with their carers and those in the sector that support them. Okay, we're going to commence tonight with a few quick poll questions to assess your current level of knowledge and also to check that you are paying attention. So these are very quick. Bertha, I'll get you to bring up the first poll. Have you participated in any intellectual disability healthcare training in the last 12 months? The webinar tonight is presented as a component of the PHN's GROW project, which is part of the federally funded Primary Care Enhancement program. This is a pilot project currently being rolled out across 4 PHNs in Australia. And the program aims to give people with intellectual disability better access to appropriate quality health services that meet their needs. As part of this program, this training is designed to improve your knowledge as healthcare providers of how to better support people with intellectual disability. Next question. Thanks, Bertha. The next one is, have you heard of the Intellectual Disability Annual Health Assessments? There will be 2 evaluation surveys to be completed at the end of the session. One will pop up on your screens immediately following the session, and this is quite a short survey that allows us to issue certificates of attendance. The second is a more detailed post-training evaluation survey that will be sent out with the PowerPoint slides and relevant resources. And we really appreciate your feedback on both of these evaluation surveys. And the final question, Bertha, before we move on, how confident do you feel engaging with or treating patients with intellectual disability? It's just a scale there with 5 options. So ABT Associates are an external consultancy firm that have been contracted to evaluate the program across all 4 PHNs. And this evaluation will inform government decisions on further funding for this work, as well as a national rollout of the program. So we really do encourage and appreciate your feedback. And as mentioned, to taking the time to complete the evaluation surveys following the training. Okay, I'm going to thank you very much for providing that feedback. And I'm going to hand over to Kylie.
Thank you. Good evening, everyone. My name is Kylie Scott. I will introduce the other speakers shortly. But firstly, I want to share a little bit about me and why I am here. I am an artist. I run my own public speaking business, and I am an Olympic silver medalist. My passion, though, is advocacy. I have many personal reasons for this, but the main one is how hard it has been and still is for people with intellectual disability to begin their lives, let alone thrive. From before we are even born, we must fight to prove our lives are worthy of keeping. I have delivered messages on this to health professionals and politicians across Australia, but it does not end there. At the beginning, preventative healthcare plays such a vital role in our lives. People like me live to an average age of just 54 years. I am currently 42 years old. I, myself, know and am aware that living with Down syndrome has health risks. It helps me if you make yourself aware of them too. This training will cover many topics that hopefully will lead to health professionals like you being more confident in understanding that each disability has its own associated health risks. The importance and life-saving effect of preventative and holistic healthcare. communicating complex ideas in a way that we understand, and offering healthcare that is both accessible for us and that makes good business sense to you. Now that I have said my piece, Dr. Jessica Murphy, would you like to introduce yourself?
Thanks, Kylie. Hi, everybody. I'm Dr. Jessica Murphy. I'm a GP in Leichhardt. As you can probably tell from my accent, I'm actually from the UK. I did my medical training and GP training in the UK, and I worked in the UK for a couple of years before emigrating to Australia in 2018. Whilst I was in the UK, I was the clinical lead at my practice there for conducting intellectual disability annual health reviews. So I do have a bit of experience in this field, and I'm quite passionate about improving the health outcomes for this patient population. So I hope we can share some insights with you tonight.
Thank you, Jess. Claire, would you like to go next?
I would. Hi, I'm Claire. I work with Hannah on the GROW project. I'm a service navigator and educator. I run the in-practice training and I also help out with these events too. My background is I spent 4 years at the Council for Intellectual Disability, creating resources for people with intellectual disability. And now I think Jess is going to take over. So.
Thanks very much. So we're just going to talk tonight about these following learning outcomes. So we're hopefully going to identify some of the types of health conditions that people with intellectual disability experience, identify key clinical resources that can help you to manage these conditions, determine effective health interventions, and also at the end, talk about how we can make reasonable adjustments to practice for these patients. Now, I'm aware tonight that we've got a mixed audience tonight. We've got a handful of GPs, but we've got quite a few allied health professionals, nurses, and practice staff. So the makeup of my presentation is kind of GP focused. However, I'm going to kind of help you to extrapolate some of the key messages that you can put into your own sort of settings. So we're actually going to start off with some case studies. So the first case study is about Kit. So Kit is a 51-year-old man who lives with his mother, Sherry. His father, David, passed away last year. He's also got a sister, but she lives interstate. Kit's father used to drive him to work, where he restocked shelves at a small grocery store. Since his father's passing, Kit left his job because it was too difficult to get there. And his only NDIS supports cover psychology services. He's got a history of anxiety and he takes an antidepressant for this, which is an SSRI. And that was first prescribed by a psychiatrist over 10 years ago. The dose has remained stable since. In the past year, Kit has become increasingly irritable, and on 2 occasions he's actually become aggressive towards his mum, Sherry. Sherry's 76, she's got a history of osteoporosis, and she's concerned for her own safety and for Kit's well-being. As I said, Kit has seen his psychologist 6 times so far this year to try to reduce the levels of his agitation and discuss his behaviour management, but it's not working so far, and therefore they've come to you as the GP, or to me as the GP, or us as the GP for further assessment. So I'm actually going to ask us to start with a poll here, and I want us to think about what could be going on for Kit. So Bertha, if you wouldn't mind bringing up the poll for us, please. And it's just a multiple choice question. I'll give you sort of 20-30 seconds to have a look at it and think about it, and then we'll show the responses, just out of interest. Okay, I think that's enough time. So we'll see the responses, Bertha, if that's okay. Yeah, good. So quite a mixed bag, but heavily kind of, I suppose, on that kind of mental health end of the spectrum with the depression and the grief response there. So you're quite right that any of these things could be possibly going on. It could be that his mood has worsened since the death of his father, but equally we need to think of those, you know, the the physical health things that could be going on, and also the fact that he's on some medication, could that be contributing? We need to figure this out a bit more. So what are we going to do for the first thing? So the most important thing to do first is, surprisingly, speak to Kit. Now, I know you're probably thinking, why is she telling us how to take a history? Well, the main reason I brought this up is because the most common thing that patients with intellectual disability report is that, unfortunately, when they see health professionals, the health professionals usually target their questions towards their carers or the support person that's with them rather than them, without investigating whether they can speak for themselves. We don't know at this point what Kit's communication skills are like. However, even if he has difficulty with communicating, it's still important to introduce ourselves to him, to look at him, to address him, to say hello to him. And also, like any other patient, it's important to get his consent to see whether he's happy for his mum to stay in the consult with him, or whether he would prefer to speak without her and then get her in later. And we would do that for any other patient, so we should treat Kit in the exact same way. Of course, we want to gather some information about his recent symptoms, and when we do this with Kit, we find out that actually he would actually experience this better by using a body mat, a visual aid mat. And when we do this with Kit, he indicates that he's been experiencing pain in his upper and middle abdomen and also in his head, but we can't get a bit of an idea in a time frame. Now, depending how this goes, this might have taken quite some time for us to get to this point of this information, especially if we're using a visual aid map. It might take a bit longer than a standard consult. So we need to decide, do we examine him now, or do we bring him back another time to examine him later? And also it might depend on how Kit's feeling. You know, he might feel that he's a bit overwhelmed by this point. He might not be up to a physical examination. It might be a bit confronting for him. So it may be better that we reschedule another appointment and ask them to book a long appointment so that we've got time to sufficiently examine him properly. And this is what we do. And a week later, they return for a comprehensive assessment, and we examine him and we find out that he's got a distended abdomen. So we decide to get him a plain film x-ray, and it shows that he's fecally loaded and he's suffering with constipation. So we actually decide to prescribe him laxatives and ask him to increase his exercise. So what are we going to do going forwards? Well, of course, we're going to get him back again to discuss how that has that helped, and we find out that yes, it has helped, and his symptoms are better, and in turn his behaviours have improved. Beyond this, what are we going to do? Well, it would be a really good opportunity to get Kit in for an annual health assessment to find out about his overall healthcare and does he have any other health needs. And when we do this, we find out that Kit hasn't seen a dentist in over 18 months, and that's because he's been quite anxious about going to the dentist. So that would provide us with an opportunity to address this. You know, we could provide an easy read or visual resource about dental care. We could liaise with his psychologist to address his dental anxiety. And it's really important with these patients, in particular, that MDT working we use MDT working, and it's really helpful for us as GPs to get feedback from you guys as allied health professionals and vice versa, so that we can maximise the care for these patients holistically. It may be that Kit needs a general anaesthetic for his dentistry, for example, and we can explore that. And also then just looking at the other NDIS services that he could access. So maybe he would benefit from a dietitian, a nutritionist, an exercise physiologist, and also looking at preventative healthcare checks in the future. And then finally, not forgetting about Sherry's needs as a carer. You know, is she coping? Does she need any respite care? What are the plans for future care planning as Sherry's aging? And it may be that Kit and Sherry need an NDIS review to assess eligibility for extra services going forwards. So the key points that I wanted to raise in this case are really that missed health conditions are common in patients with intellectual disability. You know, from our poll that we did then, most of us thought that there was some sort of mental health problem going on with Kit, when actually it was actually constipation. And it's important that we don't overlook these common health problems just to jump straight into the behavioural issues. They also help highlight some of the adjustments that we can make for these consults. So use of visual aid maps, easy read resources, use of repeated visits and reviews. This gives us a time for extra time to spend time with the patients to explain things properly, to put them at ease, but also maximizes our billing potential with these patients because we know they can be quite complex. And also just remembering that carer support is important. And also the role of annual health assessments, and I'm going to come on to annual health assessments in a bit more detail later. So our next case is about Amelia. So Amelia is a woman in her early 20s. She's got an intellectual disability and cerebral palsy. She's able to vocalize and use sign language, but it's very difficult for people to understand her communication. This is actually the first time we've ever met Amelia. It's her first visit with us. Her previous GP, who she was with since being a child, has recently retired. Support staff inform us that Amelia has lived with them in their residential service for the past 3 years. However, she also has her mother who visits every weekend. She's got epilepsy and she's on medication for that. She has a history of trauma. She was unfortunately sexually and physically abused as a teenager by someone who wasn't a family member. In recent years, she's had mental health problems, including a suspected suicide attempt. She's also exhibited behaviours of concern, including non-suicidal self-harm. Support staff report that for the past month, Amelia has exhibited sexualised behaviours, including taking off her clothes, exposing her genitals to staff, both male and female, and touching her genitals in public. And staff report that these behaviours are becoming more frequent. They report that there's been no changes in her group home or daycare programme when the behaviours began, and there's no other signs of any mental health crises. So over to you guys. So similar as last time, I'm going to do a poll. What do we think could be contributing? So Bertha, if we could bring the poll up, please. Again, multiple choice, and what you think is most likely. And we'll give another few seconds for that. Yeah, okay, let's have a look at the answers then. Yeah, good. Okay, so again, a bit of a mix, but again, we think that there could be some trauma going on, or maybe some further abuse going on. And yeah, again, it could be any of these things. You know, could it be a medication thing? Is she on any contraceptives that could have changed that could be contributing to this? Could it be related to epilepsy? Could it be seizure related? We don't know. We need to find out. So again, what are the first steps? So in this consultation, again, as per kit, we want to speak to Amelia. She's never met us before. It's her first visit here. We want to introduce ourselves to her. We want to tell her who we are, we're a doctor, and why we're having a look at her today. Even if somebody's not able to communicate verbally, it's still important to speak to them, acknowledge their presence, and show them the respect of saying hello. Don't just direct everything to the carers. It's also probably important to find out, does the support staff who's with her know her well? Do they know how to interpret her signs? Because if not, then we're going to need to reschedule this appointment with somebody who can. And of course, because we've never met Amelia before, we're probably going to need some time to find out some history. We might not be able to do all of that today. We might need to do a file review. We might need to liaise with her mother, look at her medications, speak to the carers, get some collateral history. So we may need to actually, you know, send them away, do a bit of information gathering and bring them back. But one of the most important things, I suppose, given Amelia's past history of trauma, is making sure that she's safe. So before we let them go, find out, you know, what's in place at home for Amelia, you know, make sure that she's got adequate supervision, you know, perhaps having 2 staff members with her at all times for personal care, and making sure there's adequate support for excursions, for example. And it may be that we need to liaise with the group home and look at NDIS arrangements with regards to this before. Now, just going on to the fact that, you know, this is Amelia's first visit, we're going to need to gain a bit of trust with Amelia and build rapport. It's really easy if we can try and see these patients from childhood so that we know them well, we know the family well, and that's what she had been doing with her old GP. But because we can't do that now, then as I've said, repeated visits and annual health assessments can really help to build that rapport through. So next steps is what we've said we're going to do. We speak to Amelia, we're going to find out the information, get a collateral history, and do a bit more of a file review. And again, we can ask staff members to help with this, ask are there any other allied health professionals involved. We might want to liaise with her neurologist. And in reality, we did all of this and there wasn't anything coming out in the history as to why this was happening. So we need to do a physical examination. And physical examination in patients like this, like Amelia, who are complex, can be quite tricky. We need to be really mindful that Amelia has experienced trauma in her past, and we don't want to potentiate that trauma and inflict any medical trauma on top of that. We need to take time for Amelia to get to know us, to build trust before we start going into that examination. And it might be helpful to find out how she's tolerated examinations before with her old GP. And we might want to bring her back for a few visits just to chat to her and gain trust before we actually launch into the physical health check. Now, sometimes with patients who have physical and intellectual health disabilities, we might not be able to do a full examination like we would do in other patients, and we might need to be opportunistic in what we can do. And this can be helpful to think about for patients. For example, if patients might need a blood test doing, if they need a GA, a general anaesthetic, to be done for another procedure, for example, a dental procedure, we can actually arrange for some tests to be done at the same time whilst they're under general anaesthetic. So, for example, the Sydney Dental Hospital are pretty good at this in allowing us to arrange these things. And it can be really helpful as GPs if we know that a patient needs some screening or blood tests in the future, that maybe we give them the blood test form to have on file with them so that when they see other specialists or when they see the dentist, if there's a chance to do those opportunistic investigations at the time, they can then be done. And so therefore it's important to keep other healthcare providers informed, and that can be helpful by, like I say, providing the blood form or maybe writing a letter that they can keep in their My Health Record file that they carry with them so that they can pass that information on. But particularly in Amelia's case, it may be that, you know, she's having this genital, you know, exposing her genitals. Could it be a genital problem going on? You know, and it may be that we think she might need a genital examination. That might not be possible for somebody like Amelia. So sometimes in these patients, it's sometimes helpful to do a treat and see approach. For example, we might try and use some antibiotics and see whether that clears it without examining. We have to weigh up the risks and benefits of that. You know, if she's been having lots and lots of antibiotics and different antibiotics, that's probably not appropriate. But if she's not had any antibiotics for a while, we know she's not got any allergies, it's not going to interact with her other medications, side effects are minimal, then we might say, let's just treat her and see. So we do have to tailor these things to the individuals. It's not a one size fit all, unfortunately. But the bottom line is we need to try to find out what's going on as best as we can. And in Amelia's case, this is a true case, by the way. She had actually consulted with several allied health professionals and doctors, and sort of thought that it was a behavioural or psychological issue, but actually the eventual diagnosis was thrush. The thrush was treated and all of her behaviours completely resolved. Okay. Beyond this, obviously we're going to do an annual health assessment. We might look to see whether she needs any speech therapy and behavioural support plans. So the reason that I brought this case up is that, yes, it's a complex case, and it shows that sometimes with these patients we need to take time to methodically go through these things and see, take it step by step and take our time. And it's also important to be trauma aware. So, we might, before we do any invasive tests. But the main thing that I wanted to draw your attention to is this kind of schema at the bottom here. whenever anybody with intellectual disability comes in with a change in behaviour, it's important to go in this order. You need to rule out any physical health problems first, before moving on to potential mental health problems, before looking at the environment, and then lastly, looking at whether it's purely a behavioural issue. And by doing it in this method, we're going to avoid those common health conditions being completely overlooked, like in Amelia's case. And hopefully it gives you a bit of a system to work through. Which brings me through to this definition of diagnostic overshadowing, which is very, very common with people in intellectual disability. They've got a high potential for physical symptoms like constipation, like thrush, to be overlooked, because people automatically attribute their symptoms to a mental health or a behavioural problem. And we can help to prevent this by doing regular, thorough health checks, and by building rapport, bringing them back for visits frequently. Often people with intellectual disability are diagnosed in childhood, and then they get whisked away by the specialist paediatric teams, and the GP doesn't see them very often. They might actually be seeing the physio or the psychologist more than they see the GP. So encouraging patients to see their GP regularly for basic health checks can really help to prevent these missed conditions. And we've all got a role in reminding patients of that, and their carers, obviously. This just gives an example of common health conditions that can be overlooked. This was compiled by Professor Nick Lennox from the Queensland Centre for Intellectual and Developmental Disability. And as you can see, they're really common conditions that everybody can have. It's not anything particularly fancy or complex that you need to have lots and lots of specialist knowledge about. We all know about these things. It's things that we all see day to day. And then this is just a continuation of that list. So that brings me on to the annual health assessment and what this is. So in the poll, interestingly, I think it was 44% of you knew what an annual health assessment was, and 56% I think didn't. So I don't know if I got that the wrong way around. But for those of you that don't know what an annual health assessment is, essentially it's just a top to toe review of the health. So, you know, how's the general health, looking at the medications, are their immunizations up to date, is the screening up to date, what is the social status like, what are the ADLs like, how are they doing psychologically. It's an entire systems review. And we do this for other patient cohorts as well. We do it for elderly patients, but particularly for people with intellectual disability, it's important that we don't miss those conditions, because they're not, as we pointed out, they're not very good. It may not be very good at keeping up with things like immunisation, screening, etc. Now, whilst annual health assessments are generally performed by GPs or practice nurses, allied health professions have a role, because they could, when you know, for example, when patients are seeing you as a physio or a psychologist or a dietitian, it might be helpful for you guys to say, you know, have you had your annual health assessment? Have you seen your GP? Can you book in for that maybe before we next catch up? So you've got a role in reminding patients about it, but also, from my perspective as a GP, I find it incredibly useful to get feedback from allied health professionals, and not really just about things that we've referred them to you for. For example, you spend on average probably maybe an hour a session with patients, and often we only get 10 or 15 minutes. It may be that you pick up on something that the patient's got that we've not found. So for example, patient might go to physio wearing shorts, and they might have a big rash over their legs that when they've come to the GP, they've been wearing trousers and we've not seen, and the patient hasn't brought it up with us. It'd be really helpful for you to then, you know, either pick up the phone to us, send us a quick email, write us a letter saying, look, I saw this rash, I'm a bit concerned about it, can you have a look at it? And vice versa, it's helpful for us to probably pick up the phone to you and say, you know, this patient's got a new pain that's going on, or I'm worried about their weight, I'm worried about this. And by sharing information like this, it's really helpful, and we can improve care. And I'm going to come on to ways in a second of how we can make that cost effective for us all. The other thing that I wanted to touch on with this is about coding and the use of My Health Record. So it's really helpful for us when we see patients, and this is more for GPs and practice nurses and practice staff, for us to code things correctly in the notes. It can be helpful to code the patient as having an intellectual disability, and then in addition code the actual diagnosis, for example, Down syndrome, because this can help when we pull off recalls and for recalling them for annual health assessments. The other thing as well is the use of My Health Record, because the more information we can share between us, the better the outcomes. And if we can actively encourage to be uploaded to this and for patients to and carers be aware that it's in place, then hopefully we can streamline care a bit better. Just another point that I thought of on this slide that's specific to allied health professionals. It can be helpful for you guys, because I know you don't get much time to actually do the reports and to upload to My Health Record and communicate. So it can be helpful for you guys maybe to say to patients and carers, we're actually only going to use 50 minutes of this allocated 1 hour session to actually see you, because the extra 10 minutes I'm going to actually spend on doing a report, so that next time you see a GP or next time you see a specialist, they know what's going on. And therefore then we can all work on communicating better. Now for the annual health assessment, there's different documents. It really doesn't matter what document you use. This is one that you can get from the Department of Health. There's this one which is called the Comprehensive Health Assessment Programme. You can make your own template. It doesn't matter as long as you're doing it. Now we all know about Medicare item numbers, but the one in particular I wanted to draw your attention to on this slide is the case conference. I didn't know about this until doing this presentation, that this existed. But this is where we can do a case conference between 3 health professionals, which is, for example, the GP to allied health, or a GP, a specialist in allied health, or a GP and 2 specialists, whoever. And we can do that up to every 3 months. And it's basically where we can have an MDT discussion about the patient, and you can bill an item for that. I don't know the figures, but I suspect that they're kind of along the lines of care plan figures. Do you know the figures?
I don't know them off the top of my head.
Yeah.
But we can look at, yeah.
But I think it's just the reason I wanted to highlight that was just that you can get remuneration from talking to people. So let's try and start information sharing as much as we can. I'm going to whiz through this next case because it's a bit more complex, but this is about Amir. He's got an intellectual disability in the moderate range, and he needs support in many areas. And he communicates through basic sign language. He attended a special education program, and he had excellent support, but he had a bit of difficulty in post-school transition, and that was why he was then eventually moved into residential care. Most of Amir's care up to date has been provided by his developmental paediatrician and a paediatric neurologist, and more recently an adolescent psychiatrist. And so Amir's only really seen us very sporadically. And since transition out of children's services, he only really sees, he doesn't really see any allied health professionals anymore. He's got epilepsy, for which he's on Tegretol. His parents have made the appointment and asked the group home staff to bring him because he's been refusing to eat for the past 3 weeks. He's been a picky eater before, but it's getting worse. And recently he's been prescribed some new medication for behaviours of concern, which is risperidone, which is an antipsychotic. Amir eating has been worsened since that medication started, and 3 weeks ago he had a choking episode, and now he seems scared of eating and is refusing to eat very much at all. He's only having like a bit of banana smoothie a day. When we see Amir, he appears quite thin and underweight, and by the time we see him, unfortunately, he's been in the waiting room for 40 minutes, and he's really quite agitated, but we don't really know why. He's trying to communicate with us, but the staff member who's with him doesn't know his signs, and so it's been quite difficult. So, as before, there's lots and lots of things that could be contributing to Amir's food refusal. It could be physical things, it could be signs of abuse, it could be mental health, as we've talked about before. And as we've said before, the most important thing is to try to engage Amir, but we know he's really, really quite distressed at the moment. And is probably that we can't do anything in this appointment by this point. He's too distressed, and to try and make him go through that is just going to distress him even more. So it's probably worth just rescheduling the appointment. But as in Amelia's case, we need to make sure that Amir is safe. And for Amir at the moment, the urgent issue is hydration. So it'd be really important to, make sure that we can get an urgent swallowing assessment, and making sure that his fluids, is able to keep his fluids up. Now, we probably then want to ask the family and the group home manager to make another appointment as soon as possible when either his parents can attend or somebody who knows his signs well can attend. And hopefully we can arrange that today. Beyond that, we're going to need to do a really big file review, get collateral history from his psychiatrist, from his neurologist, do a medication review, look at his weight. And it's going to take a bit of multidisciplinary working to get all of this going. And as I've written at the bottom of the slide there, probably want to get gastro involved, salt, dietitian, and do a bit of care coordination. So the key points that the reason I've kind of highlighted this case is that communication is key. And we need to really ideally have a worker with him who knows him best, who can help us work collaboratively and can understand his communication. Now, it's not easy, and it's not up to the GP to schedule his supports. It's not, but equally we can help with that. And collaborative working between GPs, nurses, and group home visits can really help with this. And the way we can make this financially viable as GPs is delegating, can our admin team help with this? Can our nursing staff help with this? And for nurses who might not feel confident in seeing patients for health assessments, for example, it can be helpful to sit down and maybe ring carers or group home staff beforehand and find out how communication works, what the patient can tolerate, what they've had before, and this can smooth over appointments really much better. The other thing that we could consider here is scheduling appointments. So, could we think about maybe bringing patients like Hamir in early in the morning or late at night when the waiting room's a bit quieter and they're not waiting as long to see us? Could we have a place in the waiting room that's quieter, or could we ask him maybe to wait outside if the weather's not too bad, so that he's not getting too distressed? And the other thing that we could do is think about distractions. Is it possible that he could maybe wear some headphones or bring an iPad with him so that he's not getting distracted by people in the waiting room? But one of the big things I think from this case is that Amir hasn't been to see his GP very often at all. And as I said before, often with children, they do get kind of swept up in specialist teams and don't get that follow-up with the GP. And unfortunately, then sometimes when they transition back as adults, they are a bit anxious, agitated, because they don't know us, they don't have the trust with us. So one way of doing that is to actually encourage children, carers, group home staff to try and bring them in just for regular basic health assessments and chats so that we can get that rapport and hopefully minimize that distress for when something does happen like this, and also copying people into communication. Again, it highlights the multidisciplinary working. And the other thing that I'm going to just very briefly touch on is polypharmacy. Sadly, this is common in people with intellectual disability, and it can be quite concerning because some of the medications we use, particularly for behaviours of concern, like psychotropics and anticholinergic drugs, can have problems, particularly with worsening sort of cardiovascular outcomes, and can also increase risk of things like dementia, which is particularly important for people with Down syndrome. So I just wanted to bring your attention to this resource from the NHS, which is called STOMP, which can help GPs in medication reviews and reducing medications. And also another thing that we can also actively do is involve our pharmacists and using home medicine reviews, and they can let us know how we can reduce polypharmacy.
There's just a question in the chat that says, can those case conference items be held via telehealth or telephone conference?
I suspect they can. I don't have the item numbers for telehealth on me, but I suspect there will be a telehealth item number available. And I think Hannah's just looking that up right now.
Yeah, I believe that it can be, and it's about $75 if it lasts for at least 15 minutes.
Yeah, so that would be the equivalent of 36 for those GPs who are billing. So yeah, it's definitely something that's accessible and worth a try, I think. Yeah. So just moving quickly on to some resources that we've got to help us with care of these patients. So Therapeutic Guidelines, some of you may be using this already, some of you may not. It's a subscription service website that has got a suite of clinical guidelines. So this is the example page for developmental disability. But it also is a really good resource for just everything otherwise clinically. And I use it almost daily in my practice, so I really recommend it. Then I'm sure all of you are aware of Health Pathways, really, really valuable resource because it's tailored to our area. There's the Sydney one and the South Eastern Sydney one, and the login details are there for you. In particular, we've just recently updated the intellectual disability healthcare pathways, and these are the pathways that are on there. So they include clinical information on how to treat these patients within these remits, but also has local referral guidelines in there, so you can find out contact numbers for specialists, etc. Now, I know that some of you may have come to this presentation wanting to speak about specific health risks for specific syndromes. It's just not possible to talk about because there's so many different syndromes that we'd be here all night. And I know that maybe some of you as allied health professionals might be concerned when you see these patients that you don't really know much about that syndrome. My advice to you would be, don't freak out, don't panic. As a GP, I often don't know the ins and outs of some of the rarer conditions, and I have to go and look it up. And don't be afraid to reach out to us as GPs or to the intellectual disability specialists, but to get more information about those syndrome-specific health risks, because we can then say, oh, you need to watch out for this, you need to consider this, and again, that collaborative working can improve the outcomes. But if you did want to have a quick look for yourself, this link here is got some tables in there with some syndrome-specific health risks and what to look out for example, in Down syndrome or Rett syndrome or whatever it may be. And then finally, before I move on, I just wanted to highlight the role of the specialist intellectual disability health teams. They are there, but they're a limited service. They're for patients who have got complex health conditions and unresolved complex needs. They're not there just to take care of everybody with an intellectual disability. That's what we should be doing as the primary healthcare professionals, and we should only really be referring to these people when we've got those complex needs or when we need extra advice. We should be dealing with the everyday to-day health conditions, like hopefully I've drawn your attention to in this presentation. And again, just highlighting the role of the collaboration between GPs and these teams that can hopefully be started in childhood and then continued on into adulthood. And that leads me on to this video that I'm going to play for you from Dr. Vanessa Sarkozy, who's going to talk about this collaborative working in a bit more detail.
Hi, my name is Vanessa Sarkozy. I'm a developmental paediatrician at Sydney Children's Hospital in Randwick, and I'm currently head of department at Tumberton, which is the child development service based there. I think there are two populations. There's the population that really knows their GP, and their GP is their care coordinator. And then there is a population who doesn't have that relationship with a GP, and I think they have very different models of care. And that perception that the paediatrician or the specialist is the person that manages that disorder becomes more and more entrenched over time. I think the much more optimal model is that the care coordinator is the general practitioner who then pulls in additional resources as required. And as specialists, we reinforce that idea that the GP is the first port of call, and if the GP is worried, they can contact us and we can escalate that way. So like everybody else, we have a finite resource, and and it's nice to target the resource to where it's best used. It also concerns me that families often wait an extended period of time to come and see the paediatrician with disorders, conditions, concerns, which would be much better managed and much more managed in a much more timely way at the general practice, be it warts, constipation, gastroesophageal reflux, etc. By deferring care, I think that that's not the optimal outcome for the child, and it also reinforces a message for families that they have to see a specialist. And actually what the families need across all chronic disorders is a tiered approach. So they need to have a general practice who has that overview of the child, overview of the family, who understands the history and is then able to pull in additional specialist resources as and when required. I think that's the best use of health resources, but I also think it's the most appropriate model of care for families. It means they can rapidly access care when they have concerns, they have confidence in their GP, and their GP has a mechanism for pulling in additional resources or support as required. So I think there's delay. I think that's probably the most important issue. The routine healthcare is neglected, so we see conditions presenting far later than they needed to. So our capacity to change the trajectory is diminished. Some of that comes from a perception that disability is not health, or that these children are not unhealthy, which often they're not, but they're at risk of poor health, and that sort of changing that conversation for families. But my primary concern is the delay in accessing care. So if they're seeing a paediatrician every 6 months, every 12 months, that you would defer management of a treatable condition, or even assessment for a significant condition that should be actioned much more quickly. I think GPs sit in a unique space within our system, so they are often the person the family first approaches when there's a concern about language development, learning, etc. So they're aware of the initial concerns, and in an ideal model, they would then continue to carry the family whilst we did the assessments, and if we have a definitive diagnosis, we communicate that back to the GP. The GP is aware of that, and we shift from a diagnostic phase for the family to a long-term care phase. Families with children with disabilities are often highly stressed. We know that family relationship and breakdown is much more common in families where there is a child with a chronic health disorder or a disability. Having care for the whole family means that I think that the child gets better care. So having someone who understands what's happening with the sibling who maybe has developed another disorder, an elderly relative, parental mental health, family breakdown, things that are not always shared with a specialist, means that the GP is in a much better position to understand the dynamics, what's reasonable to ask of the family, the degree of stress the family's under, and when the family needs additional supports. And that may be not within my power to provide, but certainly as a paediatrician, one of the jobs you do is advocate. And I do appreciate that we have more time for that, and we have access to social workers, etc. But knowing from the GP that the family is really under stress will direct what I then decide to do with the family, or what I feel, what additional resources need to be brought in to support the family. And that additional communication, that information that the GP holds that no one else has, is critical to the long-term well-being of the family unit, and therefore the child. What I see too often, not just with general practice, but also with paediatricians, is that families stop coming. They have an answer. It's very clear that the doctors can't fix it, and therefore there's no real reason to engage in healthcare. And what we know is that with routine surveillance and health promotion, certainly in adults, we found many more health disorders which we can manage, optimize health and well-being. And I believe the same is true for children. In an ideal world, that shift to managing the child as someone with a chronic disorder means that they would get annual check-ins. You would build up that comfort for the child within clinic to have their blood pressure taken, to have a look in their ears, be weighed and measured, all the things that you really need the child to be able to tolerate as an adult to be able to continue to provide that care. It also allows for early intervention when there are problems found. So I think it's important that the GP and the family understand that there are health issues associated with developmental disorders and intellectual disability, and that connection with the GP is core to the ongoing well-being of the child and family going forward. And we shift from that investigative and diagnostic phase to a long-term health promotion and surveillance phase. From my perspective, it's very different if you know the child from 2 and 3, they grow up with you, you learn about their interests, you're able to put them at their ease, you have that connection going forward. Then if you suddenly meet someone who's 15, who's bigger than you and potentially go aggressive, it's a very different relationship, which again speaks to why that continuity of care with a GP is so important. Generally, I follow other people's leads. So if the carer comes in and the child is agitated, I would ask, what can I do to make things better? There is no one answer for everybody. It is an individual response. Sometimes it's the light in the room is too much. Sometimes it's the noise. Often waiting makes my patients very agitated. So certainly this is a population I work really hard to run to time for. They don't like hanging around in my waiting room. They don't like change, they don't like seeing different doctors, they don't like being in different rooms. So as much as I can to minimize that, and really working at the child's pace and understanding that, you know, it might take me 4 or 5 visits before I can actually get an accurate blood pressure, which is why it's important that I start taking a blood pressure when it's not clinically vital that I get a correct blood pressure. It's a skills development with the child. So we do a lot of, we put it on mum, and then we put it on the brother, and then we do it on the child, and we do it by palpation, and then eventually we get an accurate blood pressure, and the same with weights and heights and ear examinations. There has to be a really good reason, a clinical, acute reason why I would push a particular component on an examination on a child. To me, it's much more about building comfort, and coming to see the doctor is not a scary thing. Some families like to have video photo diaries. I mean, all sorts of iPad stories where, you know, we're going to go see Dr. Vanessa, and they know that Dr. Vanessa makes you weighed and makes you measured and takes your blood pressure and feels your tummy. And they can have that conversation, and they can do that pre-warning with the individual child. But mainly, it's just a matter of familiarity, of coming often enough and regularly enough in a predictable way that the child and the family feel comfortable.
I think we're going to hand over to Kylie now, so please feel free to add any questions in the Q&A. Kylie, are you ready to roll?
Yeah, thank you.
Thanks.
My turn again. And I'm sure you're all wondering, Kylie, what Olympic sport did you play to get a silver medal? Well, I represented Australia in 2 Special Olympics, the first in 2003 in Dublin, and then in Shanghai in 2007. I won silver in Dublin in 2003 for tennis. I was able to compete because the Special Olympics were accessible and organized with an understanding that everyone has different needs, even elite athletes. I have a regular appointment with my GP, so I don't have to remember to book. We can do this because I have a chronic disease management plan. Many people with intellectual disability have other underlying health conditions or health risks. So my GP found this a great way to see me regularly to deliver the preventable health care I talked about earlier tonight. Because these appointments are regular, my doctor can spread out complex and involved consultations across them, so I don't feel overwhelmed. An advantage to a recurring appointment, that is, that I know in advance when to book my NDIS support. It also helps me with blood tests and specialist appointments. For appointments that sit outside of my regular one, I ask the practice to send all communications directly to me as well as to my mum. This is an important point for so many people with ID. Sharing the responsibility with a support person I nominate not only helps me, but it also means that there are fewer missed appointments and lost billable hours. As I mentioned before, with Down syndrome, I am at a higher risk of heart conditions and Alzheimer's. Research suggests that about 50% of people with Down syndrome develop symptoms of Alzheimer's disease after the age of 40 years. How do you prepare me for this? Aside from talking with me about it, be aware of my baseline cognitive ability. This means annual health assessments are important to start at an early age. Help me understand what I can do and engage health professionals who can help me embed the needed preventative lifestyle changes. And as just mentioned earlier tonight, diagnostic overshadowing can happen. So try and exclude other medical conditions like a UTI before diagnosing Alzheimer's. Research published last year showed that people with ID have low vaccination rates and are admitted to hospital for preventable illnesses more often than the general population. Choice and control are important things for people with ID to feel they should have. The step before these is a good understanding of the why and the how. As Dr. Fernandez mentioned, if you take the time while we are young to explain the why and the how, you can build up a trusting relationship. We can feel properly prepared and empowered. This then leads us to make more informed medical choices and decisions around such things as being vaccinated. People with ID have varying abilities of communication and understanding of what is happening and being said. Please keep in mind that most of us can and do understand what is happening around us. Just because some of us cannot speak verbally or communicate with our bodies does not mean we don't get scared, confused, or angry that something has not been explained to us. I know of and use resources made to help explain the process leading up to procedures that assist with explaining hard topics like end-of-life care conversations. There are also charts that help people express pain or their emotions. Claire will speak more on this in a minute. Another thing to keep in mind, for example, when prescribing or referring, is to not take for granted that I know the process. I was recently prescribed some medication. The prescription was for half a tablet daily. My GP didn't mention I would need to cut the tablet and throw away the half I didn't take. So, When my mum picked up the prescription, she had to ask the chemist what I needed to do. They showed her and gave her a cutting implement. If my mum didn't pick up that medication, I am not sure how I would have figured it out for myself. I go through tough patches. I was treated like I was stupid at a job I had. And 4 years ago, my dad died. I also, like everyone else, just struggled with life sometimes and need mental health support to get me through. Having an intellectual disability does not mean I don't understand when I'm treated differently and take it too hard. I see so much for my mental health. They have helped me through some really tough times. Before I hand over to Claire, I just want to say thank you for taking the time to attend this training and ask you to encourage your colleagues to do the same. The more health professionals who attend training like this, the more inclusive the health system becomes for people like me. And while inclusion may seem a hard thing to get right, just imagine a health system full of people who don't even try. For me, this is just not worth thinking about. So again, thank you for coming tonight. I now hand over to Claire.
Thanks, Kylie. I'll just share my screen. Thanks again, Kylie. What a wonderful call to action. And so thank you for coming tonight and sharing your story. As Kylie mentioned, changes, even minor ones to your practice, can have a massive impact on not just a patient feeling your service is accessible to them, but it has a cumulative effect on people's long-term health outcomes. We could talk for hours on all aspects of communication and communication tools, and we live in a pretty amazing time where if you're looking for a communication aid, more often than not, someone has had the same issue before you and created a resource for it. We at Project Grow must straddle an interesting line in our work. Our project is influenced by people with lived experience and their needs and requirements to fully participate in their healthcare, along with the preventable deaths and hospital admission research. But it's also influenced by the realities of the Australian healthcare system, an industry struggling on multiple fronts, having just gone through the worst, touch wood, of the pandemic and the complexities of running a business. So our job is to find ways to embed some reasonable adjustments into the practices that make it easier for all parties. It's a tough ask, but I think we can do it. And as per usual, for all these CPD events, a PowerPoint will be sent out post this session with all the links that I mentioned tonight. But if you wanted to contact us further for more assistance, I myself and Jen are able to come and do practice visits and help you embed some of these into your practices. I might just skip over this because I know that Jess kind of talked over that. But also Jess mentioned the specialist ID teams. So I won't linger on this long, and diagnostic overshadowing. And one of the things that we have in New South Wales, and especially in Sydney, we've got the mental health hubs. These are set up by the Ministry of Health, and there are 2 hubs. One is for children and young people, and the other is for adults. And the details are on this slide. We've also partnered with SANE Australia, They are running a pilot program for a new digital mental health service, specifically supporting people with complex or co-occurring mental health needs, including people with intellectual disability. And the referrals can be made via the link that I've included there. Another thing we can't emphasise enough is the impact of early childhood intervention, that not only the impact that it has on the child, but also the family unit. These services can encompass more than just the medical intervention, referring families to the early childhood approach partner, which used to be called the Early Childhood Early Intervention, run by the NDIA, can mean a family get a bit more support to hopefully stop them from buckling and breaking under the under the commitments involved in raising children with complex care needs. Children under 7 who have a diagnosis or who don't fully meet the definition of developmental delay, but have developmental concerns, will be supported through the early childhood approach. And in the CESPHN region, those partners are LifeStart and Each. And that all those details are there. Data presented to the Royal Commission in 2021 spotlighted the horrific stats that 90% of women with intellectual disability have experienced sexual abuse. And 68% of women with an intellectual disability will be subjected to sexual abuse before they reach the age of 18. Along with 62% of people with ID having experienced violence, which is almost double that of the general population. I might pause here for those stats to sink in and then ask you to remember that when you're seeing your patients, especially women, that I ask you to engage in that trauma-informed care. Evidence suggests that compared to women without a disability, women with intellectual disability do not access cervical screening or breast screening at the same rate as the general public. It's less than 10% have a regular cervical screen. They have poorer reproductive and sexual health outcomes and have lower levels of HPV vaccine coverage. Women with intellectual disability also experience a lack of education and support in relation to menstrual management, contraception, and screening. This has implications for access to contraception, cervical screening, and STI screening, prenatal care, and places them at risk of worse health outcomes. Primary care providers have a key role in addressing these disparities and ensuring women with intellectual disability receive appropriate education and preventative health care. In 2018, Family Planning and the Cancer Institute of New South Wales joined forces to develop the Just Checking project. Just Checking aims to increase cervical, breast and bowel screening rates amongst people with intellectual disability and autism. And those tools can be found via the Just Checking website. Okay, this is Michelle. In May of 2009, Michelle, 28, and her mother presented to the ED department with a suspected ear infection. Michelle loved music and could speak for herself, but by the time she presented to the emergency department, she was exhausted and in so much pain that she wasn't talking. Even with her mother advocating for her and telling the staff that her behaviour wasn't normal, the doctor attributed her behaviour that night to her intellectual disability, wrote it off as a temper tantrum, and forcibly discharged her. Early the next morning at home, Michelle died of meningitis after her middle ear infection spread to her brain. Behaviours have meaning, and understanding or investigating that meaning literally means life or death. So with this, we ask that if carers come to you and say that their child, relative, or client's behaviour is different, or they think that they're a little not themselves, as Jess said earlier today, run those tests, ask those questions. It may not be something, but it may be something. And if that something goes unchecked, I just ask you to remember Michelle's story and to read the paper today about Jua's story. Now, reasonable adjustments. There are many ways we can adjust the way that we communicate with people, and many tools that have been developed to help within the health settings. There are tools to help conversations around supportive decision-making and hard conversations. Research shows that many people with intellectual disability encounter death without being included in the process, be it a family member is dying or when they themselves approach death. Many people don't know what to say, so they don't include the person with intellectual disability in the conversation. This can be extremely stressful, ostracizing, hurtful, and potentially dangerous for the person with intellectual disability. But luckily, like I mentioned before, if you Google supporting people with ID through death, there are multiple resources that come up. There are also a few resources that have been developed locally to assist during health appointments. My Health Matters is a communication folder that I led the co-design on while I was at Council for Intellectual Disability. The folder includes a variety of communication tools and can assist many varying communication styles and needs, from pointing out pain to being able to show where you sit with your mental health on any given day without having to talk to anybody. Similarly, the admission to discharge folder, or A to D, was developed by ADDIC back in the day for group home residents to take with them in an emergency or a hospital stay. Both these folders have a tool called the top 5, and it's pretty straightforward. In this section, you put the top 5 most important things to know about that person, and those top 5 things that people need to know. Within consultations and particular procedures, the Say Less, Show More cards that were created by the Agency for Clinical Innovation have developed a set of tools to use that include lots of pictures that talk through medical processes and procedures. But there are, as I said, there are so many tools out there. You name it, if you've got a problem, someone's developed a resource for them. Some of which have been the Council for Intellectual Disability. They're working on health resources at the moment, and they're developing lots of tools to be used within consultation that go through particular conversations that you'll have to have. They are very good at developing easy read resources that are good for people with intellectual disability. The easy read resources are on the next page I'll show you is an easy read is a format that is known across the world as a formula or a format for people with intellectual disability to understand what you're talking about in an easier way. So the photo, with the photo next to the text, the photo contextualize what the text says, and time again, people with intellectual disability say that it makes understanding what's written on the page so much easier. So I know that you're probably at information overload, so I won't go on for much longer, but there are many ways to adjust your practice with or without tools. A reasonable adjustment can be as simple as asking if your patient understood what you said, and asking them to repeat back to you what they think you said is a good way to understand whether they have fully computed the information. Another example would be tweaking the way that we approach correspondence outside of appointments, because we can't assume that a patient can access written communication. We suggest asking a patient how they need to be communicated with. Do you need me to call instead of send you a text? In regards to those important recalls or reminders. And perhaps they need you to send their communication, as Kylie said, to someone else other than them. Why? Because these steps will ensure that communication is received, understood, and the important things actioned. Supported decision making. We'd like to say just start with the assumption that all people have the capacity to make their own decisions. At times, everyone needs support to make a decision, advice from the hairdresser about hairstyles or advice from a lawyer about legal issues. People with intellectual disability are expected to make their own decisions and should be provided with the support to do this. Breaking down big concepts and using visual aids, like I mentioned before, when possible. I'll touch briefly just on behaviours. Some of the people that we've talked with about seeing patients that have concerning behaviours is to consider meeting those patients or participants with behaviours or sensory sensitivities outside of practice. Consider offering telehealth or home visits to eliminate the risk of waiting room disruption or unnecessary stress on the patient. But really, our take-home message for this cohort is that there is no one-size-fits-all approach. There are many barriers that prevent this population receiving effective healthcare, and everyone has different adjustments that they require. Talking to your patients with ID and asking them what will make your practice or your consultations more accessible, and conducting annual health assessments, like we've said a few times tonight, is a great place to start. And as mentioned earlier, the GROW team has capacity to provide in-practice support to implement strategies and workshop solutions for your practice and your patients, whether that be individuals or group homes, or whether you have a significant patient cohort or not. We're available to help upskill clinicians, PMs, as well as administration staff and allied health. And we're happy and ready to provide that support. So I will finish up there. I will ask Hannah if there's been any questions in the question box.
Thanks, Claire. I will take a stop that video again. We do actually have a couple of questions. So how can practice nurses prepare for annual health assessments? So I'll hand this over to Jess.
So I think the key thing I think would be initially to take some time to maybe have a chat with the GP about what they already know about the patient and what their specific maybe concerns are, or medical concerns may be, or things that they may want you to spend more time on than others. And then also then, as I think I mentioned before, maybe liaising with the patient ahead of the appointment, either directly with the patient or their carer or their group home or their support worker. So it's best to organise how that session is going to look like. Do they need any communication aids? Is it going to be able to be achieved in one sit-down session? Do you need to bring them back and split it over a couple of sessions? Can you do any information gathering via telehealth prior to bringing them in to minimise time and to minimise any distress? And just kind of probably put in a bit more preparation into it than you probably would with just a normal over 75 health assessment, for example. I know a lot of you are really experienced in doing the health assessments. You're familiar with the key domains, but it's just about kind of tailoring it, as we've talked about, with those reasonable adjustments. Yeah.
Thanks, Jess. And another question which we've been receiving as a team quite a lot recently as well. How can you support an adult patient who you suspect has an intellectual disability, but has never had a formal diagnosis?
Yeah. Jess, did you want to answer that?
Well, I mean, from my point of view as a GP, my first go-to for information would be health pathways. There's a suite on, as I said, there's a suite of information on there, and there's one in particular about genetics with intellectual disability, and there's lots of referral resources there for clinical genetic teams. And my other thought would be reaching out to the specialist intellectual disability teams for any advice there about referral. But I'd be interested to hear what Claire's been training in the practices.
No, you answered exactly how I would. Yeah, the specialist ID teams are probably the best port of call. We know that there are extensive waits for other places, but they've got their finger on the pulse as to what the capacity of different places are and whether they've got that capacity themselves. So yeah, it would be the specialist ID health teams.
Thanks, Claire, and thanks, Jess. That's all of the questions. Oh no, we've just got one coming in. When appointments are made, how do reception staff flag a person that a person has an intellectual disability to maybe allow GPs time to prepare for the appointment?
That's a great question, and I think it's, again, unfortunately it's not a one size fits all, because every practice has different operating systems. But I think one of the ways that can be helpful from the way our practice works is having alerts that pop up on a patient's note. So for example, we use a booking system called Praxsoft. So you can put warnings on there so that when a receptionist checks the patient in, it pings up, this patient's got an intellectual disability, and therefore then that they can then make them comfortable in the waiting room, or be aware that they might need some special assistance. And then the other thing is coding correctly in the notes. So, you know, making sure that it's coded as an intellectual disability or their specific diagnosis. And then again, maybe putting that in the warning section of the notes. So again, I use medical director, there's a warning box, and you could put it in there in capital letters, has an intellectual disability, so that if they're seeing a new GP who doesn't know them, they automatically can see that and can then adapt and adjust. And same with practice nurses, they'll be using the same software, you know, within the practice. And then if you have a practice that has a high population of intellectual disability patients, it might even be worth keeping like a register of those patients so that you can alert practice staff and make them aware of who those patients are. Because hopefully if you're doing this like we would like you to, and doing it, you know, thoroughly, these patients will be coming in frequently, and then you can flag them and people will know ahead of time. Yeah.
Thanks, Jess. Another question's just popped up. Can you comment on how you cope with the financial burden or expectation for these more complex patients in a very difficult financial climate for GP practices at the moment?
It's not easy, and the way I personally deal with it is just repeated visits, breaking it all down into small chunks so that you're, you know, you're not spending lots and lots of time and not being remunerated. Making sure that you're maximizing use of your care plans, your GP management plans, your health assessments, and then also using telehealth as well. You know, telehealth, if it's a bit like with children, you know, when you do a telehealth for a child, you speak to the mum, but you can still bill the mum for that telehealth consult. So the same way you might want to be doing a telehealth call to the support worker to gather information about the patient. If the patient's present at the time of that call, you can then bill that as a telehealth item. So it's just kind of trying to be a bit clever with your billing. Of course, I'm not advocating that we commit fraud, but, you know, for example, if you need to split a health assessment over a few appointments, could you use one of the sessions to do basic examinations like blood pressure, height, weight, blood sugar or something, and then bill that as an item 23, and then half of that information you're going to use in your health assessment that you can then bill the next one for the actual health assessment. So I think it's just trying to be inventive, trying to use repeated visits, but I agree, it's not easy. Yeah.
On that point, a real emphasis from one of our other GP advisors has been around ensuring that your clinical information systems are up to date. So really putting in that extra effort to make sure that referral letters or discharge letters, and it does take some chasing around, optimizing the use of practice staff and practice nurses when they're available and they have capacity to make sure that all that relevant information is on your clinical information system. So when it does come to making a new referral or doing an annual health assessment or whatever it may be, that information is there. You're not trying to chase up 10 different members of the multidisciplinary team to try and get that information.
And I think if you put that initial legwork in and spend as onerous as it is all of these repeated visits, that's only going to be for a short amount of time till you really get to know the patient. And then hopefully once you've covered all of that initial legwork, then subsequent visits will be much easier because you'll know that patient really well and you'll know the family. And that's the benefit of trying to keep families and children with you from that very early onset, and try and maintain a relationship as patients from an early age, so that you know the problems, you know the family. It makes it much less complex down the line than somebody who you're meeting as a teenager or as an adult with a whole host of problems and they try to unpick. So yeah.
Thanks, Jess. We'll probably just go on to one last slide before we let everyone go for the evening. These, as we discussed, this training today is provided as part of CESPHN's Project Grow, which is part of the Primary Care Enhancement Project. This project will be run through till mid 2024, and we'll be running these training sessions about 4 times a year. So if you have enjoyed the session, you think that would be relevant to any of your colleagues, then please do tell them about it. We have another session booked specifically focusing on allied health later on in the year. So please disseminate that information. As mentioned, we have our service navigators that are also providing that in-practice support. So every practice is different. We have heard all sorts of different strategies on how practices manage and I guess try to improve health outcomes and provide more effective care for people with intellectual disability. It really is a whole of practice approach. It comes from allied health, from practice staff, admin staff, nursing staff, practice manager. It really requires everybody getting on board. And I guess what we can offer is coming out to your practices and providing support on that. So looking at what quality improvement activities might be relevant, looking at how you're managing your identification of people with intellectual disability within practice software, looking at embedding forms into your practice software, embedding flags and all of that. So if you're interested in any of that, please get in contact. Claire will go on to the next slide, which includes our contact details, but we'll also circulate information in the resource pack after this webinar. So thank you very much. Thanks all for joining us tonight. Thank you, Jess. Thank you, Kylie. Thank you, Claire. And thank you, Jen and Bertha from the PHN team as well. Really appreciate everyone joining tonight. Have a lovely evening. Thank you.